2020 ESC Guidelines for the Management of Acute Coronary Syndromes, in patients presenting without persistent ST segment elevation. What to do, and what not to do, messages. Recommendations for diagnosis, risk stratification, imaging, and rhythm monitoring, in patients with suspected non-ST segment elevation, acute coronary syndrome. Diagnosis and risk stratification. It is recommended to base diagnosis and initial short-term risk stratification on a combination of clinical history, symptoms, vital signs, other physical findings, ECG, and laboratory results, including high-sensitivity cardiac troponin. Class 1 Level B. It is recommended to measure cardiac troponins with high-sensitivity assays immediately after admission, and obtain the results within 60 minutes of blood sampling. Class 1 Level B. It is recommended to obtain a 12-lead ECG within 10 minutes after first medical contact, and to have it immediately interpreted by an experienced physician. Class 1 Level B. It is recommended to obtain an additional 12-lead ECG, in case of recurrent symptoms or diagnostic uncertainty. Class 1 Level C. The ESC 0-hour/1 hour algorithm with blood sampling at 0 hour and 1 hour is recommended if an high-sensitivity cardiac troponin test, with a validated 0-hour/1 hour algorithm is available. Class 1 Level B. Additional testing after 3 hours is recommended if the first two cardiac troponin measurements of the 0-hour/1 hour algorithm are not conclusive, and the clinical condition is still suggestive of ACS. Class 1 Level B. As an alternative to the ESC 0-hour/1 hour algorithm, it is recommended to use the ESC 0-hour/2 hours algorithm, with blood sampling at 0 hour and 2 hours, if an high-sensitivity cardiac troponin test, with a validated 0-hour/2 hours algorithm is available. Class 1 Level B. Additional ECG leads, V3R, V4R, V7 to V9, are recommended if ongoing ischemia is suspected, when standard leads are inconclusive. Class 1 Level C. For initial diagnostic purposes, it is not recommended to routinely measure additional biomarkers such as HFABP or coptin, in addition to high-sensitivity cardiac troponin. Class 3 Level B. Imaging. In patients presenting with cardiac arrest or hemodynamic instability, of presumed cardiovascular origin, echocardiography is recommended, and should be performed by trained physicians, immediately following a 12-lead ECG. Class 1 Level C. In patients with no recurrence of chest pain, normal ECG findings, and normal levels of cardiac troponin, preferably high sensitivity, but still with a suspected ACS, a non-invasive stress test, preferably with imaging, for inducible ischemia, or coronary CT angiography is recommended, before deciding on an invasive approach. Class 1 Level B. Echocardiography is recommended to evaluate regional and global LV function, and to rule in or rule out differential diagnoses. C. Class 1 Level C. Coronary CT angiography is recommended, as an alternative to invasive coronary angiography, to exclude ACS, when there is a low to intermediate likelihood of coronary artery disease, and when cardiac troponin, and/or ECG, are normal or inconclusive. Class 1 Level A. Monitoring. Continuous rhythm monitoring is recommended, until the diagnosis of NSTEACS has been established or ruled out. Class 1 Level C. It is recommended to admit NSTEACS patients to a monitored unit. Class 1 Level C. Rhythm monitoring up to 24 hours or to PCI, whichever comes first, is recommended in NSTEACS patients, at low risk for cardiac arrhythmias. D. Class 1 Level C. Rhythm monitoring for greater than 24 hours is recommended in NSTEACS patients, at increased risk for cardiac arrhythmias. Class 1 Level C. Recommendations on biomarker measurements for prognostic stratification. Beyond its diagnostic role, it is recommended to measure high-sensitivity cardiac troponin serially, for the estimation of prognosis. Class 1 Level B. The measurement of additional biomarkers, such as mid-regional prototype natriuretic peptide, high-sensitivity C-reactive protein, mid-regional proadrenometalin, GDF15, copeptin, and HFABP, is not recommended for routine risk or prognosis assessment. Class 3 Level B. Recommendations for antithrombotic treatment, in non-ST segment elevation acute coronary syndrome patients, undergoing percutaneous coronary intervention. Antiplatelet treatment. Aspirin is recommended for all patients without contraindications, at an initial oral loading dose of 150 to 300 mg, or 75 to 250 mg intravenous, and at a maintenance dose of 75-100 mg OD for long-term treatment. Class 1 Level A. AP2Y12 receptor inhibitor is recommended in addition to aspirin, and maintained over 12 months, unless there are contraindications, or an excessive risk of bleeding. Class 1 Level A. Options are: prasugrel in P2Y12 receptor inhibitor naive patients, proceeding to PCI, 60 mg loading dose, 10 mg per day as standard dose, 5 mg per day for patients aged greater than or equal to 75 years, or with a body weight less than 60 kg. Class 1 Level B. Ticagrelor, irrespective of the planned treatment strategy, invasive or conservative, 180 mg loading dose, 90 mg BID. Class 1 Level B. Clopidogrel, 300 to 600 mg loading dose, 75 mg daily dose, only when prasugrel or ticagrelor are not available, cannot be tolerated, or are contraindicated. Class 1 Level C. Treatment with GP2B/3A antagonists, in patients in whom coronary anatomy is not known, is not recommended. Class 3 Level A. It is not recommended to administer routine pretreatment with AP2Y12 receptor inhibitor, in patients in whom coronary anatomy is not known, and an early invasive management is planned. Class 3 Level A. Peri-interventional anticoagulant treatment. Parenteral anticoagulation is recommended for all patients, in addition to antiplatelet treatment, at the time of diagnosis and, especially, during revascularization procedures, according to both ischemic and bleeding risks. Class 1 Level A. Unfractionated heparin, weight-adjusted intravenous bolus, during PCI of 70 to 100 IU/kg, or 50 to 70 IU/kg, in combination with a glycoprotein 2B/3A inhibitor, activated clotting time target range of 250 to 350 s, or 200 to 250 seconds if a glycoprotein 2B/3A inhibitor is given, is recommended in patients undergoing PCI. Class 1 Level A. In cases of medical treatment, or logistical constraints, for transferring the patient to PCI within the required time frame, fondaparinux is recommended and, in such cases, a single bolus of unfractionated heparin is recommended at the time of PCI. Class 1 Level B. It is recommended to select anticoagulation according to both ischemic and bleeding risks, and according to the efficacy-safety profile of the chosen agent. Class 1 Level C. Crossover of unfractionated heparin and low molecular weight heparin is not recommended. Class 3 Level B. Recommendations for post-interventional and maintenance treatment, in patients with non-ST segment elevation acute coronary syndrome. In patients with NSTEACS treated with coronary stent implantation, dual antiplatelet therapy with a P2Y12 receptor inhibitor, on top of aspirin, is recommended for 12 months, unless there are contraindications, such as excessive risk of bleeding. Class 1 Level A. Recommendations for anti-ischemic drugs, in the acute phase of non-ST segment elevation acute coronary syndrome, sublingual or intravenous nitrates, and early initiation of beta blocker treatment, are recommended in patients with ongoing ischemic symptoms, and without contraindications. Class 1 Level C. It is recommended to continue chronic beta blocker therapy, unless the patient is in overt heart failure. Class 1 Level C. Intravenous nitrates are recommended in patients with uncontrolled hypertension, or signs of heart failure. Class I Level C. Recommendations for combining antiplatelet agents and anticoagulants in non-ST segment elevation acute coronary syndrome patients requiring chronic oral anticoagulation. Stroke prevention should be offered to AF patients with greater than or equal to 1 non-sex CHA2DS2 VASC stroke risk factors, score of greater than or equal to 1 in males or greater than or equal to 2 in females. For patients with greater than or equal to 2 non-sex stroke risk factors, oral anticoagulation is recommended. Class 1 Level A. Patients undergoing coronary stenting. Anticoagulation. During PCI, additional parenteral anticoagulation is recommended, irrespective of the timing of the last dose of all non-vitamin K antagonist oral anticoagulants, and if INR is less than 2.5 in VKA-treated patients. Class 1 Level C. Antiplatelet treatment. In patients with AF, and CHA2DS2 VASC score greater than or equal to 1 in men and greater than or equal to 2 in women, after a short period of triple antithrombotic therapy, up to 1 week from the acute event, dual antithrombotic therapy is recommended as the default strategy, using a non-vitamin K antagonist oral anticoagulant at the recommended dose for stroke prevention, and a single oral antiplatelet agent, preferably clopidogrel. Class 1 Level A. Periprocedural dual antiplatelet therapy administration, consisting of aspirin and clopidogrel up to 1 week is recommended. Class 1 Level A. Discontinuation of antiplatelet treatment, in patients treated with an oral anticoagulant, is recommended after 12 months. Class 1 Level B. The use of ticagrelor or prasugrel, as part of triple antithrombotic therapy is not recommended. Class 3 Level C. Recommendations for coronary revascularization. Timing of invasive strategy. An immediate invasive strategy, less than 2 hours, is recommended in patients with at least one of the following very high-risk criteria. Class 1 Level C. Hemodynamic instability or cardiogenic shock. Recurrent or refractory chest pain despite medical treatment. Life-threatening arrhythmias. Mechanical complications of MI. Heart failure, clearly related to NSTEACS. Presence of ST segment depression greater than 1 mm in greater than or equal to 6 leads, additional to ST segment elevation in AVR and/or V1. An early invasive strategy within 24 hours, is recommended in patients with any of the following high-risk criteria. Diagnosis of NSTEACS, suggested by the diagnostic algorithm recommended in Section 3. Dynamic, or presumably new contiguous ST/T segment changes, suggesting ongoing ischemia. Transient ST segment elevation. Grace risk score greater than 140. Class 1 Level A. A selective invasive strategy, after appropriate ischemia testing, or detection of obstructive coronary artery disease by coronary CT angiography, is recommended in patients considered at low risk. Class 1 Level A. Technical aspects. Radial access is recommended as the standard approach, unless there are overriding procedural considerations. Class 1 Level A. Drug-eluting stents are recommended over bare metal stents for any PCI irrespective of clinical presentation, lesion type, planned non-cardiac surgery, anticipated duration of dual antiplatelet therapy, concomitant anticoagulant therapy. Class 1 Level A. It is recommended to base the revascularization strategy, ad hoc culprit lesion PCI/multivessel PCI/coronary artery bypass grafting, on the patient's clinical status and comorbidities, as well as their disease severity, i.e. the distribution, and angiographic lesion characteristics, for example syntax score, according to the principles for stable coronary artery disease. However, the decision on immediate PCI, of the culprit stenosis, does not require heart team consultation. Class 1 Level B. Recommendations for myocardial infarction with non-obstructive coronary arteries. In all patients with an initial working diagnosis of MINOCA, it is recommended to follow a diagnostic algorithm, to differentiate true MINOCA from alternative diagnoses. Class 1 Level C. It is recommended to perform CMR in all MINOCA patients without an obvious underlying cause. Class 1 Level B. It is recommended to manage patients with an initial diagnosis of MINOCA, and a final established underlying cause, according to the disease-specific guidelines. Class 1 Level C. Recommendations for non-ST segment elevation acute coronary syndrome patients, with heart failure or cardiogenic shock. Emergency coronary angiography is recommended in patients with cardiogenic shock, complicating ACS. Class 1 Level B. Emergency PCI of the culprit lesion, is recommended for patients with cardiogenic shock due to NSTEACS, independent of the time delay from symptom onset, if the coronary anatomy is amenable to PCI. Class 1 Level B. Emergency coronary artery bypass grafting is recommended for patients with cardiogenic shock, if the coronary anatomy is not amenable to PCI. Class 1 Level B. It is recommended to perform emergency echocardiography without delay, to assess LV and valvular function, and exclude mechanical complications. Class 1 Level C. In cases of hemodynamic instability, emergency surgical or catheter-based repair of mechanical complications of ACS is recommended, as decided by the heart team. Class 1 Level C. Routine use of intra-aortic balloon pump in patients with cardiogenic shock, and no mechanical complications due to ACS is not recommended. Class 3 Level B. Routine immediate revascularization of non-culprit lesions in NSTEACS patients, with multivessel disease, presenting with cardiogenic shock is not recommended. Class 3 Level B. Recommendations for diabetes mellitus in non-ST segment elevation acute coronary syndrome patients. It is recommended to screen all patients with NSTEACS for diabetes, and to monitor blood glucose levels frequently in patients with known diabetes, or admission hyperglycemia. Class 1 Level C. Avoidance of hypoglycemia is recommended. Class 1 Level B. Recommendations for patients with chronic kidney disease, and non-ST segment elevation acute coronary syndrome. Risk stratification in CKD. It is recommended to apply the same diagnostic and therapeutic strategies in patients with CKD. Dose adjustment may be necessary, as for patients with normal renal function. Class 1 Level C. It is recommended to assess kidney function by eGFR in all patients. Class 1 Level C. Myocardial revascularization in patients with CKD. Use of low or isoosmolar contrast media, at lowest possible volume, are recommended in invasive strategies. Class 1 Level A. Recommendations for older persons with non-ST segment elevation acute coronary syndrome. It is recommended to apply the same diagnostic strategies in older patients as for younger patients. Class 1 Level B. It is recommended to apply the same interventional strategies in older patients as for younger patients. Class 1 Level B. The choice of antithrombotic agent and dosage, as well as secondary preventions, should be adapted to renal function, as well as specific contraindications. Class 1 Level B. Recommendations for lifestyle managements, after non-ST segment elevation acute coronary syndrome. Improvement of lifestyle factors, in addition to appropriate pharmacological management, is recommended, in order to reduce all-cause and cardiovascular mortality and morbidity, and improve health-related quality of life. Class 1 Level A. Cognitive behavioral interventions are recommended, to help individuals achieve a healthy lifestyle. Class 1 Level A. Multidisciplinary exercise-based cardiac rehabilitation is recommended as an effective means for patients with coronary artery disease, to achieve a healthy lifestyle and manage risk factors, in order to reduce all-cause and cardiovascular mortality and morbidity, and improve health-related quality of life. Class 1 Level A. Involvement of multidisciplinary healthcare professionals, cardiologists, general practitioners, nurses, dietitians, physiotherapists, psychologists, pharmacists, is recommended in order to reduce all-cause and cardiovascular mortality and morbidity, and improve health-related quality of life. Class 1 Level A. Psychological interventions are recommended to improve symptoms of depression in patients with coronary artery disease, in order to improve health-related quality of life. Class 1 Level B. Annual influenza vaccination is recommended for patients with coronary artery disease, especially in the older person, in order to improve morbidity. Class 1 Level B. Recommendations for pharmacological long-term management after non-ST segment elevation acute coronary syndrome, excluding antithrombotic treatments. Lipid-lowering drugs. Statins are recommended in all NSTEACS patients. The aim is to reduce LDL cholesterol by greater than or equal to 50% from baseline, and/or to achieve LDL cholesterol less than 1.4 millimoles per liter, less than 55 mg/deciliter. Class 1 Level A. If the LDL cholesterol goal is not achieved after 4 to 6 weeks with the maximally tolerated statin dose, combination with ezetimibe is recommended. Class 1 Level B. If the LDL cholesterol goal is not achieved after 4 to 6 weeks despite maximally tolerated statin therapy and ezetimibe, the addition of a PCSK9 inhibitor is recommended. Class 1 Level B. ACE inhibitors or ARBs. ACE inhibitors, or ARBs in cases of intolerance to ACE inhibitors, are recommended in patients with heart failure with reduced left ventricular ejection fraction, less than 40%, diabetes, or CKD unless contraindicated, for example severe renal impairment, hyperkalemia, etc., in order to reduce all-cause and cardiovascular mortality and cardiovascular morbidity. Class 1 Level A. Beta blockers. Beta blockers are recommended in patients with systolic LV dysfunction or heart failure with reduced left ventricular ejection fraction, less than 40%. Class 1 Level A. MRAs. Mineralocorticoid receptor antagonists are recommended in patients with heart failure with reduced left ventricular ejection fraction, less than 40%, in order to reduce all-cause and cardiovascular mortality and cardiovascular morbidity. Class 1 Level A. Proton pump inhibitors. Concomitant use of a proton pump inhibitor is recommended in patients receiving aspirin monotherapy, dual antiplatelet therapy, dual antithrombotic therapy, triple antithrombotic therapy, or oral anticoagulant monotherapy, who are at high risk of gastrointestinal bleeding, in order to reduce the risk of gastric bleeds. Class 1 Level A. CHA2DS2VASC equals congestive heart failure, hypertension, age greater than or equal to 75 years, 2 points, diabetes, stroke, 2 points, vascular disease, age 65 to 74, sex category, female. C does not apply to patients discharged the same day in whom NSTEACS has been ruled out. D. If none of the following criteria: hemodynamically unstable, major arrhythmias, left ventricular ejection fraction less than 40%, failed reperfusion, additional critical coronary stenosis of major vessels, complications related to percutaneous revascularization, or GRACE risk score greater than 140 if assessed. E. If one or more of the above criteria are present. F. For patients at very high cardiovascular risk, such as patients with ACS, an LDL cholesterol reduction of at least 50% from baseline and an LDL cholesterol goal less than 1.4 millimoles per liter, less than 55 mg/deciliter, are recommended.